To begin with the next session, may I please request Dr. Shorangshu Chatterjee, Dr. Bijay Prakash Pandey, Dr. Orijit Ghosh to join the session as respected chairpersons and panelists. And to begin with the session, Dr. Prithwiraj Bhattacharya will be our first speaker. This session will discuss cases on heart failure in specific phenotypes. So, requesting Dr. Prithwiraj Bhattacharya to begin with his presentation. Over to the respected chairpersons and panelists. Yeah, so Dr. Prithwiraj Bhattacharya, you are requested to kindly begin with your presentation.
Yes. Am I audible?
You are audible and your screen is also visible to us. Thank you.
Okay, that's good. So, respected chairpersons and my colleagues, today my topic is a talk on hypertrophic cardiomyopathy, specifically the heart failure in a specific subset of hypertrophic cardiomyopathy. So, you know that hypertrophy is a globally prevalent and common genetic disease with the autosomal dominant pattern of inheritance with the sex distribution of 50-50, though the women are diagnosed less commonly. And disease prevalence is approximately 1:200 from 1:500. And usual triggers for evaluation include the symptoms, cardiac events, heart murmur, abnormal electrocardiogram, cardiac imaging, and family studies. Almost 2/3 of HCM patients have LV outflow tract obstruction, and 1/3 don't have any LV outflow tract obstruction. There are some other non-HCM causes of LV hypertrophy, which we should know and be able to differentiate from the disease. Now, defining hypertrophic cardiomyopathy in 2023, we look at it as a morphologically, its morphologic expression is confined solely to the heart, and it is characterized by a left ventricular hypertrophy with basal anterior septum usually is in continuity with anterior free wall. No other cardiac, systemic, or metabolic disease is capable of producing the magnitude of hypertrophy present, and disease-causing sarcomere or sarcomere-related variant is identified, or sometimes genetic etiology is unresolved. In adults, the diagnostic criteria in the 2D echocardiography or cardiac MRI is the maximum end diastolic LV wall thickness of more than equal to 15 millimeter. In some patients, maximum end diastolic LV wall thickness may be 13 to 14 millimeter with a family member of HCM with HCM diagnosis or in conjunction with positive genetic tests. Some other non-diagnostic morphologic abnormalities which are associated with hypertrophic cardiomyopathy include the systolic anterior motion of the mitral valve, hyperdynamic LV function, hypertrophic and apically displaced papillary muscles, myocardial crypts, anomalous papillary muscle insertion in the anterior mitral leaflets, elongated mitral leaflets, myocardial bridging, and sometimes also RV hypertrophy. The adverse events which are usually associated with hypertrophic cardiomyopathy include sudden cardiac death, progressive functional limitation, atrial fibrillation, heart failure, and thromboembolism. With improvement in risk stratification and wide use of ICD implantation, the risk of sudden death has diminished significantly, and hypertrophic cardiomyopathy mortality rates are now less than 1% per year in US population. But now the greatest unmet treatment need is in adult is heart failure. And if we look at this chart, the main culprit for symptoms of heart failure in HCM patients is LV outflow tract obstruction. Either at rest or provocation, it is present in approximately 2/3 of the patient, that is 75% of patients, and a peak LVOT outflow gradient of more than 30 millimeter of mercury is considered to be indicative of obstruction. Because of septal hypertrophy and long mitral leaflets and anterior displacement of the papillary muscle, there are abnormal flow vectors around the LV outflow tract. Along with systolic anterior motion of the mitral valve, this gives rise to LV outflow tract obstruction. Ultimately, there is increase in the left ventricular systolic pressure, giving rise to left ventricular hypertrophy, myocardial ischemia, prolonged ventricular relaxation time, and there may be variable location of this outflow tract obstruction. There may be a dynamic obstruction, there may be a combined obstruction, or mid-cavitary gradient. because of hypertrophic papillary muscles. And sometimes there is compensatory midventricular hyperkinesis because of an apical infarction or apical obliteration, anomalous papillary muscle insertion. Ultimately, all these might result in a mitral regurgitation, which also gives symptoms of heart failure. A resting or provoked gradient of more than 50 millimeter of mercury is generally considered to be the threshold for septal reduction therapy in patients who are drug refractory. In diastolic dysfunction, if we look at the pathophysiology, in these patients have impaired cellular mechanisms with altered systolic diastolic coupling and impaired cardiac cellular energetics, altered ventricular load because of high intragravitary pressure and non-uniformity in contraction and relaxation. And there is also chamber stiffness, which gives rise to myocardial hypertrophy, ischemia, interstitial fibrosis, giving rise to decreased stroke volume and left ventricular cavity size. And ultimately, there is also left atrial dilatation and fibrosis, giving rise to atrial fibrillation, which only exacerbate the symptoms. Now, the pathological mechanism of myocardial ischemia, there is also microvascular dysfunction, giving rise to reduced density of arteries due to medial hypertrophy and impaired coronary flow reserve, myocardial hypertrophy, giving rise to oxygen demand supply mismatch, giving rise to myocardial ischemia. There are symptoms of angina, heart failure, sometimes ventricular arrhythmia, LV aneurysm, and diastolic dysfunction. So there are some difference between the conventional patients of heart failure and patients with HCM and heart failure. If you look at this chart closely, the annual mortality in non-HCM heart failure is about 10%, whereas the mortality is extremely low. In obstructive HCM, it is 0.5%, whereas in non-obstructive HCM, it is almost nil. And most of the patients with obstructive HCM has a preserved LV ejection fraction type of heart failure. In non-obstructive HCM, also 95% patients has a heart failure with preserved ejection fraction. And only 5% patients in non-obstructive HCM may progress to an end-stage heart failure, that is decreased EF, about 5% of the patients. LV outflow tract obstruction is present in 70% of HCM patients, which are not usually present in other heart failure subsets. And hospitalization is very uncommon in patients with obstructive HCM patients with features of volume overload or pulmonary ankle edema. These are extremely rare. So definitely this is a less burden to the health infrastructure. And what are the determinants of exertional symptom, heart failure symptoms? LV outflow tract obstruction, giving rise to impaired LV filling, myocardial ischemia, reduced output, mitral regurgitation, ultimately giving rise to NYHA class 2 to 4 symptoms. And this chart shows the progression of severe heart failure. In non-obstructive HCM, only 10% of patients may progress to NYHA class 3 to 4. When there's a provocable obstruction, of approximately 20% patients ultimately progress to NYHA class 3, 4, and at rest obstruction patients, about 38% may reach that symptomatic stage of class 3 or 4. In non-obstructive patients, the ultimate treatment in an end stage is transplant or cardiac synchronization therapy. In obstructive patients, the treatment is either myectomy or alcoholic septal ablation in selected group of patients. If we look at the pharmacological therapy for LVOT obstruction, mainly when there is a symptom of LVOT obstruction, non-vasodilating beta blockers are first choice. When they are not effective, CCB is given, and disopyramide may be added over that if the symptoms are still severe. Ultimately, the choice might be septal reduction therapy in eligible patients. In patients
Speaker
with
is muted. Hello.
Hello.
Speaker is muted. We can't hear anything. Hello. Kosha. Prithwiraj, তোর mute করা আছে Prithwiraj. Prithwiraj, you are on mute.
Sorry, so I'll try to check that.
Hello. Hello.
Hello.
Prithwiraj, you are on mute.
As I can see, I am unmuted. Can you hear me?
Prithwiraj, we can't hear you. You are on mute.
Prithwiraj Bhattacharya.
Unmute yourself.
I have already unmuted myself. Can you hear me now?
Yes. Yes, you are audible now.
Okay. So the LVOT obstruction we are talking about, if the LVOT obstruction is present with dyspnea and volume overload, we can use a low dose of diuretic for symptom relief. And verapamil is potentially harmful in severe dyspnea at rest and very high gradients in children with very less than 6 weeks of age. And we must discontinue vasodilators, digoxin, and high dose diuretics in obstructive patients. In non-obstructive patients, usually ARB or S inhibitor has the role is not well established, and therefore treatment includes either beta blocker or CCB. In dyspneic patient, diuretic may be added. And persistent dyspnea or apical HCM patients, we can consider for GDMT for heart failure with preserved ejection fraction. Apical myomectomy is another option. In asymptomatic patients with no obstruction, the role of beta blocker or CCB is not well established. Looking at the invasive management in obstructive patients with NYHA class 3, 4 symptomatic despite GDMT, the septal reduction therapy in an experienced center is the choice. First choice is myectomy. It is recommended and associated with conditions where surgical treatment is necessary. And alcoholic septal ablation is also recommended if surgery is contraindicated or the risk is unacceptable. Invasive treatment for symptomatic patients, there are some general eligibility criteria that include severe dyspnea or chest pain, NYHA class 3, 4 symptomatic, or occasionally other exertional syncope like near syncope situation when attributable to LVOTO, hemodynamics, dynamic LVOT gradient at rest or physiologic provocation with approximate peak gradient of more than equal to 50 mm of mercury associated with septal hypertrophy, and anatomic criteria is targeted anterior septal thickness sufficient to perform the procedure safely and effectively in the judgment of individual operator. Another issue to discuss in HCM is atrial fibrillation. The risk is high in this group of patients because of increased atrial pressure and increased atrial size leading to atrial fibrosis, or there sometimes may be primary atrial myopathy giving rise to atrial fibrillation. And symptom burden, if the patient is asymptomatic, then or there is a paroxysmal AF rate control with beta blocker or calcium channel blocker is the first choice. If the patient is become severely symptomatic, and then we can go for ablation therapy either with catheter ablation, or the patient is going for a myocardial reduction therapy, myectomy, then associated MACE procedure may be planned. The risk of stroke, if we look at this chart from this meta-analysis, it was shown that there is 27% prevalence, that is 3.75% per year risk of stroke in patients with HCM with atrial fibrillation, whereas in a patient with CHA2DS2-VASc score of 2, the risk is only 3.71% per year. So HCM represents an independent risk factor for stroke in patients with HCM. So CHA2DS2-VASc score is not a good option to assess the risk of stroke in patients with HCM, and there is a HCM-AF score proposed, which there are multiple points, include the age at clinical evaluation, age at initial HCM diagnosis, left atrial dimension, and heart failure symptoms. And there is a point system where point is less than 17, it is considered as low risk. Point between 18 to 21, there is intermediate risk of atrial fibrillation, and when the score is above 22, the risk is high, more than 2% per year risk of stroke. So for current guidelines, atrial fibrillation in hypertrophic cardiomyopathy should receive drugs at the first line, irrespective of the CHA2DS2-VASc score. Vitamin K antagonists are the second line of choice, and for rate control strategy, we can use beta blocker, verapamil, or tritiazole. Catheter ablation is class 2A indication in patients with poorly tolerated AF when drug therapy is ineffective. In patients with undergoing myectomy, surgical AF ablation may be beneficial. Oral anticoagulation as per ESC guideline, current guideline also, as patients with HCM must receive oral anticoagulation as a class 1B indication, irrespective of CHA2DS2-VASc score. The unmet needs include the current medical therapy that doesn't specifically targeted for HCM, and septal reduction therapy is for intractable symptoms, and it is also not widely available. Experienced centers are needed. And additionally, there is an unmet need for non-invasive therapies to SRT for highly symptomatic patients with obstructive HCM. So the new molecule in the block is mavacamten. It's first-in-class cardiac myosin inhibitor specifically developed to target the underlying cause of HCM. It inhibits cardiac myosin and reduces excess actin myosin cross bridge. It is found to improve alveolar gradient, quality of life. And Explorer HCM, it was evaluated. It's a pivotal multicenter randomized trial. This, after a screening period of 35 days, double-blinded placebo-controlled treatment was continued with either mavacamten or placebo for 30 weeks, and post-treatment there was 8 weeks of evaluation. And after that, a long-term evaluation study is also planned. Primary outcome was more than 1.5 ml per kg per minute increase in consumption of oxygen with more than 1 NYHA class improvement, or 3 millimeter per kg per minute increase in the oxygen consumption with no worsening of NYHA class at 30 weeks, which occurred in 37% in mavacamten group. Other features like secondary outcome, Kansas City cardiomyopathy score, and LV mass index also improved with mavacamten with some decrease in the LV ejection fraction. And long-term extension study also developed described that it's a safe option with progressive improvement of the symptoms. So the follow-up study with Valor HCM was another study which also showed there is significant improvement with mavacamten, and this study included patients who were already referred for septal reduction therapy, and in this group of patients also after a initial treatment of 16 weeks, it was shown that mavacamten, the patients on mavacamten has reduced risk, the need of septal reduction therapy at the end of 16 weeks compared to placebo. This is a chart showing mavacamten versus placebo, and patients who improved with that mavacamten, a significant improvement, either class more than 1 class or more than 2 class improvement is much higher compared to placebo with mavacamten. LVOT gradient, Valsalva LVOT gradient, Kansas City cardiomyopathy questionnaire, clinical summary score, all improved with mavacamten with comparable LV ejection fraction difference. So I'll go to my last conclusion. So the last ESC updated guideline, it has shown who are symptomatic even with a treatment regimen of beta blocker and calcium channel blocker, and who are candidates for septal reduction therapy, you can add this molecule as a class 2A recommendation. And to conclude, heart failure in HCM contrasts sharply with conventional HCF with much smaller healthcare burden. Majority of symptomatic patients can be managed by drug therapy alone. In selected patients, septal reduction therapy is beneficial, and mavacamten is a promising alternative to SRT in patients not responding to the conventional therapy. Thank you.